Welcome to the Room Now podcast. Hi, I'm Dr. Jack Cush, and it's Friday the 13th, 2023. Let's start this week with what I think is really a great overview of polymyalgia rheumatica. Sarah Mackey and colleagues published this week in Lancet a full read review. You got to download this. You got to read it. It's a great reference. It covers all the concerns that you may have, and it's available this week in Lancet. It's called a seminar, sort of like an overview or review. The few bullets that I put down when I tweeted this out was, we all know the starting dose is 12.5 to 25 of prednisone. If you were on this week's Tuesday Night Rheumatology, we had a great discussion led by David Liu on steroids and PMR. And our panelists, almost across the board, Max Yates, Lindsay Lawley, and Richard Conway, David Liu, all said their starting dose is 15, and they seldom go above 30. Anyway, the review says 12.5 to 25 per day is starting dose. While many or most will achieve remission on the way to remission and during tapering, 40 to 60% will relapse. We know that. That's the difficult part of managing PMR. We all know that the onset is pretty quick in PMR, and that stiffness in the morning does predominate. The thing that I have learned this past 2 weeks with all these experts on PMR putting up written and video and audio content is really the dominance of shoulder complaints. Bilateral shoulder complaints is more prevalent than is the hip girdle musculature. In fact, having isolated hip girdle musculature would be, I think, a red flag in trying to make that diagnosis. And Dr. Mackey's review says about 50% of PMR patients will have distal symptoms. So you shouldn't say it's not PMR because the wrists are swollen or the fingers are achy or there's knee pain. Anyway, I think the big thing this month that's underscored in this review is that ultrasound's a very useful tool, and the criterion, that the ultrasound criterion that can be used for diagnosis would be bilateral subacromial or subdeltoid bursitis. Other forms of inflammation can be seen, but those are criterion. There's another interesting article. It's about relapse. It's a large study from 2005 that I thought was worth putting up, given the discussions had this week on the website about PMR and relapse. 364 patients, average age almost 73. 284 were treated with steroids. Well, that's kind of interesting, isn't it? 80 out of 360 not treated with steroids. What's going on there? Anyway, when they looked at those who had relapse, the factors that were predictive was a higher initial corticosteroid dose and a faster corticosteroid taper. Relapse is fourfold higher when you tapered the steroids too fast, hazard ratio 4.3. So what's going on there? Higher doses leading to relapse. Either that means higher doses meaning worse patients. And then maybe because you don't want to be on high dose steroids, maybe you go too fast, right? That's one way of looking at why higher doses I don't know that higher doses in itself is the predictor. I think it's the story behind the higher doses that leads to why those people might need a much slower taper. So anyway, the takeaway on this article was minimize the dose and taper slowly. That seems reasonable. Minimizing dose probably is, the higher the dose you use, obviously you cover a greater percentage of people who will get better, but I think maybe it's also setting expectations with patients. If you're giving too high a dose of steroids, they're going to love that really high dose, and getting off that's going to be difficult, and that's another reason why they may flare. Anyway, be careful with your initial dose of steroids, and obviously the slow taper is important. A study from Turkey, and it's a cohort study of all 1,100 psoriatic arthritis patients, looked at their onset period, and they wrote about the diagnostic delay. So this was a big thing, 10, 20 years ago, and we don't talk much about delay in diagnosis, and I still think it's a big problem. mainly because you, the rheumatologist, don't advertise who the primary care doctor should send to you. You don't facilitate that, and most of you do not have an early arthritis clinic or an early PSA clinic or a fast track clinic for PMR. So it's not surprising that delays occur. In this study in Turkey, the mean delay was 35 months, the median delay 12 months. Obviously, there's a skew there. About a third were diagnosed within 3 months. Congratulations. But 2/3 were diagnosed within 2 years. The good news is that the delay in diagnosis has dropped from 60 months to 24 months prior to 2010 to more recently in 2019. The factors that did contribute to a diagnostic delay were less education on the part of the patient, arthritis presenting before the skin disease, psoriasis, and low back pain as the initial symptom. Those all make sense to me, and I do think that we do need to be more proactive about how we get patients into our clinics, especially the people that you think you can do the most good for. A really novel study was published this week. I think it was in Annals of Rheumatic Disease by David Felsen and colleagues. You know, if you want to study osteoarthritis, as Felsen and a lot of others have, the animal model is you cause knee instability by either clipping the meniscus or an ACL, and you run, or a cruciate, and you run the dog, and then you get accelerated fast osteoarthritis. This study basically lays out a template as to how you can get basically make a human model. And what they have is a large cohort, what's called the MOON study, of 2,300 adults who are undergoing post-traumatic ACL reconstruction surgery. And then, as you can imagine, most of those are young. Most of those don't have pre-existing osteoarthritis. And when they follow that cohort, they find 16 to 26% will have ongoing mild to moderate pain measured in several different ways. But the idea of having joint instability caused by ACL damage and then repair, and then ongoing pain and resuming activity, that's the model for accelerated osteoarthritis, is it not? So they thought that this would be a good situation where you could study interventions, either lifestyle or drug or intra-articular, etc. I thought it was a novel way of looking at osteoarthritis going forward. In Korea, they now have a Galaxy watch, Samsung Galaxy watch, that will be approved by the Korean Health Ministry for the detection of sleep apnea. Many of us have smartwatches, Apple watches. I use something called a Mi Band watch that monitors my sleep and steps and oxygen level and heart rate and even breathing, but it doesn't really look for the ingredients of sleep apnea. In 2024, this Galaxy watch will be approved in Korea, not the United States, not the rest of the world, for the detection of sleep apnea, and will do so by monitoring blood pressure, heart rhythms, blood O2 levels, and breathing. I thought that was novel because one of the biggest problems we have is in the early detection of sleep apnea, getting patients to go to get a proper sleep study, either in a sleep lab or even at home. It's just like pulling teeth, getting people to get these things done, which will really help their health. Anyway, this is a step forward. A study of the reproductive health of scleroderma patients was looked at with 342 all forms systemic sclerosis, and they found in this study 32% had some form of reproductive problems. And this included earlier menopause, 45 years versus 48 years. More spontaneous abortions, 12 versus 4%. More premature births, 22 versus 6%. Low birth weight, 27 versus 5%. Obviously, the higher number is a scleroderma patient. The lower number is the age-matched population. More C-sections in scleroderma as well, 49% versus 19%. Interestingly, no reports of increased infertility in patients with systemic sclerosis. If you're a muscle nut like me, you like these kind of data about prevalence and epidemiology. A well-done report shows that the incidence is 0.2 to 2 cases per 100,000 patient years, with an overall prevalence of about, 2 to 25 per 100,000 in the population, making it a rare condition. The incidence rates and prevalence rates do vary with geography and with gender, but they did note that these inflammatory myopathies are still underreported in South Africa, Africa, South America, and Asia. So it tends therefore be, a Northern European, Scandinavian, largely Caucasian disorder, although we certainly see it in other racial groups and pretty much in all genders. A few years ago in Grand Rounds at University of Texas, we were having combined conference with our pediatric rheumatology department, and our pediatric rheumatologists were asserting that anakinra can be associated, or IL-1 inhibition can be associated with hepatotoxicity. And I said, I don't know about that. I did the original research in anakinra and its use in rheumatoid arthritis, leading to its FDA approval. Done a lot of anakinra studies and whatnot, and used a lot of anakinra in treating patients with systemic JIA Still's disease. Anyway, it turns out that they were right, and I was not aware of the cutting edge that they were aware of, and that is hepatotoxicity can occur with anakinra and also, by the way, other IL-1 inhibitors. It's been reported quite a bit in pediatric rheumatology patients, obviously getting anakinra either for autoinflammatory conditions or Still's disease, and these are mainly taking the form of LFT elevations, usually not to the point of liver damage, and it is sort of a drug-induced syndrome, so you stop the drug, the liver dysfunction does go away. And they had 3 case reports. I put those up, and interestingly, that was the default diagnosis, even though there are other reasons such patients would have LFT elevations. So their systemic inflammatory disease, like Still's disease, well known, 40 to 60% will have LFT elevations. The development of macrophage activation syndrome, which is LFTs are a hallmark feature. Other drugs that they may get. Anyway, even when those are excluded, IL-1 inhibition can be associated with LFT elevations. You might want to look for that. I think the big news of the week, at least according to our website, is that the FDA approved the IV formulation of secukinumab, an IL-17 inhibitor, previously, as you know, approved for a lot of different things, adults and kids. But now the IV formulation has only been approved for adults with psoriatic arthritis, ankylosing spondylitis, and non-radiographic axial SpA, all 3 of them, okay? So now you have options in your patients where you can use IV or subcutaneous secukinumab to treat psoriasis or psoriatic arthritis, AS, non-radiographic axial SpA, and enthesitis-related arthritis in the youngins. What do you need to know about this subcutaneous formulation? It's given as a half-hour infusion. It's like all your other infusion therapies, and it's like the package insert has shown a difference between a loading dose and not a loading dose. If you're using a loading dose, and you don't have to use a loading dose in PSA, AS, and non-radiographic axial SpA, but if you do, it's 6 milligrams per kilogram given at week 0. And thereafter, all infusions are every 4 weeks, where the usual dose is 1.75 milligrams per kilogram given every 4 weeks. You do not exceed an IV dose of greater than 300. In looking through the package insert, I see no other concerns or red flags. It does say, check for TB prior to or with the start of therapy, and because that's what it said for secukinumab before. Do I believe IL-17 inhibition is a risk factor for TB? No, I don't. Why then is it in the package insert? Because that's the way the studies were done. And that's it, pure and simple. Your risk of TB, as you know, very, very high with TNF inhibitors. TNF inhibitors, and TNF inhibitors, and maybe anything that inhibits interferon to some extent. But all the other biologics we use have very low risk, and if they get them if you see TB events on other biologics, B-cell inhibitors, T-cell inhibitors, whatever, it's because you're in a high endemic area or it's a very fluke event. Whereas there's a biologic rationale for the risk with TNF inhibitors. So that's the big news on secukinumab. Again, another report enforcing that the COVID experience has been a challenge for rheumatic disease patients. So a study of over 350,000 COVID-infected individuals compared to 6.1 million controls shows that COVID infection increased the risk of alopecia areata, and this is new cases, new reports, by 12%. Alopecia totalis by 74%. ANCA-associated vasculitis, almost threefold or 300% increased risk. Crohn's disease and sarcoidosis also increased. And other studies have said almost the same thing. I guess the point is that that spike protein and infection is a stimulus that generates an innate immune response. It is a pathogen-associated molecular pattern leading to the inflammasome being activated, and some people that's sort of the trigger that they need to become an autoimmune state. Interesting. Lastly, we're going to end with the CDC MMWR report of this week, actually published today, the 13th, that there are 53.2 million people with diagnosed arthritis. This data comes from their periodic surveys using the National Health Information Survey, NHIS, usually an in-home, person-to-person survey of all kinds of medical conditions and health practices, a large sampling. This particular sampling was done 2019 to 21, hence it was interrupted by COVID and the pandemic, and they reverted to telephone interviews to collect a lot of this data. So what do we know? Basically, first, 21% of U.S. adults have diagnosed arthritis. This is different than self-reported arthritis, where the numbers are higher. But their prior survey, I think, was 58.5 million, and I'll tell you why it's lower now. So this 21% is 53 million. It turns out that anyone who has comorbidities, the ones that you worry about, diabetes, COPD, heart disease, cancer, CVA, etc., 52 to 63% of those patients also report diagnosed arthritis. Not surprising, arthritis is more common in women than men, 21 versus 16%. Veterans versus non-veterans, 24 versus 18%. Non-Hispanic whites was the highest ethnic group. And then adults over the age of 45 really represent about 88% of all U.S. adults who have arthritis. So as I said, this number is below that reported in the 2016-2018 NHIS prevalence survey, where it was, 58.5 million or 23.7%. Reasons why it may be lower is that in this recent time frame, they had to redesign the survey to make it more efficient. So not all the same questions are there from the old survey, and there are some new ones. And then you can also interject the potential for some bias induced by the pandemic and the different data collection process that they went through. Anyway, that's it for this week on the podcast. I hope you saw this week's Tuesday Night Rheumatology, Steroids and PMR. Oh my goodness, what a great hour. Tons of great questions. You really should listen to that podcast or look at that video. It features David Liu, Lindsay Lawley, Richard Conway, and Max Yates, all doing a fabulous job. This next week coming up, Sebastian Satui is going to lead a discussion on steroid-sparing therapy in PMR. I think you're going to find that one really interesting as well. That's it. Have a great week. Be well.